Hello my dear, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have a very special topic, which is uterine arteriovenous malformation. This is a very important subject. So what are the objectives? To know the definition of arteriovenous malformation, terminology, pathology, classification of arteriovenous malformation, epidemiology, clinical presentation, diagnosis, and lastly the treatment of arteriovenous malformation. Okay. So let us start with the definition. Uterine arteriovenous malformation results from the formation of multiple arteriovenous fistulas communications within the uterus without an intervening capillary network. As we know, arteriovenous malformation can occur in any part of the body. Here we are talking about arteriovenous malformation in the wall of the uterus. Okay, so uterine arteriovenous malformation results from formation of multiple arteriovenous fistulas communications within the uterus without an intervening capillary network. This could be congenital or acquired. So is it common? No, it is rare condition, but I think it is increasing nowadays due to certain risk factors. So uterine arteriovenous malformations are uncommon but potentially life-threatening condition. That's why it is very important. It could be a life-threatening condition. They can be congenital or acquired, and they should be suspected in cases of severe or persistent uterine bleeding. So let us talk about certain terminology. The term uterine arteriovenous malformation has been used interchangeably with enhanced myometrial vascularity in the literature. Okay, so we can use uterine arteriovenous malformation or enhanced myometrial vascularity. You can find in report both of them in some radiological reports. The terms have been used to describe sonographic appearance of hypervascular lesion within the uterine myometrium that demonstrates turbulent flow. Okay, what happened later on? The World Congress of the International Society of Ultrasound in Obstetrics and Gynecology 2015 recommended that enhanced myometrial vascularity is the preferred term for what was previously known as an acquired uterine arteriovenous malformation. Okay? So what about the pathology? Uterine arteriovenous malformation consists of proliferation of vascular channels with fistula formation and an admixture of small capillary-like channels. The size of these vessels can vary considerably. Is the pregnancy play a role in arteriovenous malformation? Yeah. Pregnancy appears to play an important role in the pathogenesis of uterine arteriovenous malformation. It is suggested that these malformations may arise when venous sinuses become incorporated in scars within the myometrium after necrosis of the chorionic villi. So what about classification of arteriovenous malformation? Could be congenital or acquired one. Congenital tend to have multiple feeding arteries, central needles, and numerous large draining veins. And the congenital arteriovenous malformations result from a defect in the differentiation of the primitive capillary plexus during fetal angiogenesis. So congenital uterine arteriovenous malformation can happen as any arteriovenous malformation in the body. That's why when you diagnose it in certain organ, you should search for others, for other malformation. Okay? Okay. So, why it happened? Defect in the differentiation of the primitive capillary plexus during fetal angiogenesis. This capillaries is not present and there is connection between arteries and the veins, branches of the uterine artery and the venous plexus. What about the acquired one? The acquired is called also traumatic one. Acquired or traumatic uterine arteriovenous malformation. Also, it is called arteriovenous fistula. This represents multiple small arteriovenous fistula between intramural arteries, arterial branches, and the myometrial venous plexus. So, branches of the uterine artery and the venous plexus. They typically represent a single artery joining a simple vein. This abnormal connection may form after a surgical procedure such as endometrial curettage or cesarean section. So here the risk factor here is endometrial curettage or cesarean section or myomectomy or any surgery related to the uterus. Okay? So what about the epidemiology? Is it common problem? No, it is uncommon. Arteriovenous malformation in the uterus is uncommon, but potentially life-threatening condition. Which age is affected more? The childbearing age between 20 and 40 years old. And it is also more commoner in multipara than nullipara. As I said before, if you remember, when I said pregnancy has an important role to play in such malformation. And you should know also that this uterine arteriovenous malformation are less common after menopause. And as I said before, it can be classified as a congenital or acquired. Which one is commoner, the congenital or acquired one? The acquired one is more common, and that's why it is increasing nowadays because of increasing risk factors, increasing rate of cesarean section, increasing rate of DMC operation. So that's why it is more commoner. So acquired one is more common than the congenital one. Although arteriovenous malformations are relatively rare, with fewer than 150 cases reported in the literature, the true incidence of uterine arteriovenous malformations may be higher. Okay. So as I said, acquired arteriovenous malformation is more common than congenital, and its incidence is increasing and are associated with conditions such as, what are the risk factors that increasing the incidence of acquired arteriovenous malformation in the uterus? Multiple pregnancies, miscarriage, endometritis, gestational trophoblastic disease, previous surgery, like what? Like DMC, dilatation and curettage, like cesarean section, like myomectomy, like termination of pregnancy. So all of these are risk factors. That's why the incidence is increased. Please look to this systematic review published 2016, and they mentioned some of the risk factors. DMC occurred in about 62% of cases. Cesarean section was associated in 26% of cases. Uterine instrumentation procedures like hysteroscopy, like IUD insertion, like placental delivery, associated in 4% of cases, myomectomy in 4% of cases, gestation trophoblastic disease or tumor in 4% of cases. So the published cases here in this systematic review was 54, and this risk factors in this table tell you something, that the occurrence of DNC as a risk factor was the highest, 62%, cesarean section 26%. This is the associated clinical history of these cases with arteriovenous malformation. This is alarming for us. Okay, what about the clinical presentation? Could be asymptomatic. Yeah, uterine arteriovenous malformation could be asymptomatic. But if symptomatic, uterine bleeding is the major presenting symptom, and it may be massive and life-threatening in young women. Bleeding is often intermittent and profuse. What is the pattern of bleeding? Either heavy menstruation, what's called in the past menorrhagia, or irregular uterine bleeding, metrorrhagia, or menometrorrhagia, or even postcoital bleeding. All of these patterns of bleeding have been described as a presenting symptoms. These patients may also present with anemia and hypotension secondary to acute blood loss. Usually this patient come to emergency department in a hospital complaining of abnormal uterine bleeding that may affect the general condition, causing anemia and hypotension, and they receive blood transfusion, and then the bleeding stops. Then the patient is discharged. After 1 or 2 weeks or more, the patient come again complaining of severe attack of bleeding, and they receive non-specific hemostatic, then go home after blood transfusion and cessation of bleeding without being diagnosed. This is a problem. Okay? What else in clinical presentation? Postmenopausal bleeding may happen, but rarely, because this malformation is less common after menopause. What about the asymptomatic patient? May later develop symptoms following uterine trauma or secondary to hormonal changes related to pregnancy or the menstrual cycle. What else in clinical presentation? The patient may complain of vague pelvic discomfort, urinary symptoms like polyuria and incontinence. Also may have complaint like dyspareunia. Okay, this is very important. If arteriovenous malformation affecting the pelvis, also may cause vulval varicose vein. What else in clinical presentation? A history of recurrent spontaneous abortion may also place a patient at higher risk for acquired uterine arteriovenous malformation, possibly due to the increased vascularization and the resultant physical alteration of the embryo's implantation site. So when you are taking a history from a patient and you found recurrent miscarriage, and the patient coming for you complaining of abnormal uterine bleeding, please remember this. This patient may be at higher risk for acquired uterine arteriovenous malformation. Why? Due to increased vascularization and the resultant physical alteration of the embryo's implantation site. What else in clinical presentation? Pelvic pain, including neuropathic pain such as sciatica, can also be a presenting symptom. Also, congestive heart failure, although it is rare, but may happen, secondary to deshunting of the blood to the venous system if there is major arteriovenous malformation in the uterus. What about the diagnosis? Comprehensive history taking and the clinical examination to identify risk factors and make differential diagnosis for women of a childbearing age presenting with abnormal uterine bleeding in the form of either secondary postpartum hemorrhage, menorrhagia, or metrorrhagia. Okay? Acquired uterine arteriovenous malformation should be considered in patients with appropriate history and presenting symptoms, as I mentioned before. The typical treatment options for uterine bleeding, such as DMC, can cause uterine trauma and paradoxically worsen the bleeding in the presence of an acquired arteriovenous malformation. DMC is therefore contraindicated in those patients with suspected acquired arteriovenous malformation. So, please, when you see a patient with abnormal uterine bleeding, don't rush to do in treatment to do DMC. Just try to diagnose first. Because if you are suspecting uterine arteriovenous malformation, DMC will make the condition more worse and the bleeding will be horrible. So take care about this, because DMC is considered the uterine trauma and will cause this arteriovenous malformation to be the cause of horrible bleeding. If there is increased bleeding during a DMC performed for abnormal uterine bleeding, then uterine arteriovenous malformation should be suspected and the appropriate precautions taken for the possibility of ongoing severe hemorrhage. If you are already doing DMC and you are surprised with severe bleeding, put in your mind that this case may have arteriovenous malformation. So all precautions should be taken. Diagnosis of arteriovenous malformation is generally performed radiographically. The first imaging is ultrasound, pelvic ultrasound, transvaginal ultrasound is very important, not only for diagnosing uterine arteriovenous malformation, but also to exclude other causes like retained product of conception, like any other pelvic lesions, okay, like gestational trophoblastic tumor, like subinvoluted uterus. So we are starting with the transvaginal ultrasound. It can be non-specific with a range of manifestation, including the presence of, in case of uterine arteriovenous malformation, what is the picture seen by transvaginal ultrasound? Tubular, as in this picture, hypoechogenic structure in the myometrium. Can you see this one with arrow? Here within the myometrium, tubular, hypoechogenic structure in the myometrium. As a definitive diagnosis based on grayscale ultrasound imaging is difficult alone, Doppler imaging is imperative to the diagnosis. As you can see in this picture, the color Doppler. So you can't depend alone on transvaginal ultrasonography. Please do also color Doppler. It will give help. So as regard transvaginal ultrasound, you will find tubular hypoechogenic structure in the myometrium. What about color Doppler ultrasound. Typically, as in this picture, shows a low resistance, high velocity flow pattern with color mosaic. A low resistance, high velocity flow pattern with color mosaic. Doppler ultrasonography should always be performed to diagnose unexplained uterine bleeding. The prevalence of vascular lesion in the uterus is increasing with increasing cesarean section and D&C rates. Okay, so when you have a case with abnormal uterine bleeding and it is unexplained, you can't find any cause, please be careful to do color Doppler ultrasound. If there is suspicious of arteriouterine arteriovenous malformation, what is the picture? A low resistance, high velocity flow pattern with color mosaic, as in this one. Okay. If you are suspecting by the TVS, the tubular hypoechoic structure, or the mosaic pattern with color Doppler with high velocity, go on to confirm with MRI. So MRI can give benefit in diagnosis of uterine arteriovenous malformation, and it is recommended for the evaluation beyond ultrasound for uterine arteriovenous malformation when indicated, particularly in cases when acoustic windows are limited by body habitus. MRI finding including what? Include serpiginous signal voids in the uterus and enhancement of the signal voids on rapid data acquisition during infusion of contrast. MRI provides better tissue contrast and help delineate the surrounding pelvic organ involvement. By the way, MRI will help you to know if the cause of the bleeding related to the endometrium or uterine cavity, like retained product of conception, or the cause inside the myometrium due to uterine arteriovenous malformation. So, yes, MRI can differentiate, of course, if the lesion inside the muscle wall of the uterus or it is in the endometrium. So it is important to differentiate acquired arteriovenous malformation in the uterus from retained product of conception. Acquired arteriovenous malformation primarily involves the myometrium, while retained product of conception primarily involves the endometrium. The diagnosis can be confirmed when these imaging findings are coupled with maternal serum HCG, which has a slower decline in retained product of conception. What is the imaging modality next? As I mentioned before, transvaginal ultrasound, color Doppler ultrasound, MRI, and now angiography. Digital subtraction angiography shows high arterial flow with early venous filling. This picture shows angiography and the embolization also. And this picture on the left, pre-embolization, before embolization. As you see here, this is the arteriovenous malformation. Okay, and this is the post after embolization. So, digital subtraction angiography show high arterial flow with early venous filling. Angiography helps to identify the leading vessel, what we call it feeder, the feeder vessel, Radiographic angiography remains the gold standard. Angiography should be offered in consideration for a possible therapeutic option following diagnostic confirmation. So, before you are going to do angiography, because angiography is diagnostic and therapeutic also. Okay? You should counsel the patient about that it is a diagnostic and a therapeutic tool. Because I can do embolization to stop the bleeding by closure of this vessel. Okay? So what is the differential diagnosis for uterine arteriovenous malformation? The primary differential diagnosis in ultrasound imaging appearance is enhanced myometrial vascularity. Other causes of enhanced myometrial vascularity like adenomyosis, like subinvolution of the placental bed after delivery. Okay? This can be distinguished on digital subtraction angiography. So angiography play an important role in such condition. Other causes of secondary postpartum hemorrhage: if serum beta HCG is elevated, consider gestational trophoblastic disease or retained product of conception. Why? Because in retained product of conception, abnormality centered on endometrium rather than myometrium, and this is associated with still elevated beta HCG. Okay, so ask for beta HCG if you are suspecting gestational trophoblastic disease or retained product of conception, which can be diagnosed by imaging like MRI and also by beta HCG to differentiate it from uterine arteriovenous malformation. What about treatment? Different treatment modalities is present. There is no guidelines according to the different therapeutic modalities up till now. Maybe because it is a rare condition, uterine arteriovenous malformation is considered rare, with few reported cases all over the world. But different modalities include expectant or medical management, uterine artery embolization, which play an important role in the management, laparoscopy with bipolar coagulation of the uterine arteries, laparoscopic occlusion of the internal iliac arteries, and hysterectomy. For many years, hysterectomy and uterine artery embolization carry the important or the major role in the management. Of course, uterine artery embolization is less invasive than surgical hysterectomy and also used to preserve the uterus if the patient wanted to preserve her fertility. So uterine artery embolization is used more frequently than other lines of treatment. Okay, let us see in details the lines of treatment. According to the expectant or medical manager, what is meant by expectant? Conservative or just follow up, because spontaneous closure of arteriovenous malformation within the uterus may happen in 6% of cases. Okay, this line of treatment, expectant or medical management. What is the medical management? To give the patient hormones like danazol, like COC, combined oral contraceptive, like progesterone, like in some situation emblanon therapy, which is subdermal implant, or methotrexate, especially if there is cesarean scar pregnancy. This is the medical treatment. Expectant, as I said before, there is no treatment, just follow up. Spontaneous closure may happen in 6% of cases. This is a line of treatment called expectant or medical management. Is it commonly used? No, uncommonly performed. This line of treatment is uncommonly performed. There has been increasing interest in expectant or medical management of uterine arteriovenous malformation in hemodynamically stable patients. So, this category of patient in which you are going to give them this line of treatment, the expectant or medical, should be hemodynamically stable. In 1996, the first case of successful regression of uterine arteriovenous malformation in a patient receiving methyl ergonovine malate. In 1997, the first case of spontaneously resolved uterine arteriovenous malformation in patient with post-cesarean arteriovenous malformation of the uterine cervix. What else? The first case of regression of uterine arteriovenous malformation after using the oral contraceptive pills was reported in 1999. In 2011 systematic review, those undergoing conservative therapy with either expectant management or methyl ergometrin malate treatment remained representing a significantly smaller proportion of cases than those managed with uterine artery embolization or hysterectomy. As I mentioned before, the majority of patients treated by uterine artery embolization or hysterectomy. The minority, about 6% of cases, managed expectantly, follow up. And those who was given ergometrin constitute 6% also. So the majority in this systematic review, the treatment was uterine artery embolization or hysterectomy. Other reported medical treatment options including gonadotropin releasing hormone agonist, also aromatase inhibitors, also tranexamic acid in order to control bleeding. Methotrexate has also been described in cases associated with cesarean scar pregnancy. This is as regard the expectant or medical management. Next, very important line of treatment, and many cases nowadays are managed by this line of treatment, which is uterine artery embolization. Uterine artery embolization is performed more commonly. The procedure involves angiography of the uterine vasculature, followed by obstruction of the blood flow through the uterine arteries using an embolic material such as polyvinyl alcohol particles, stainless steel, or hemostatic gelatin. As you see in this picture, this is before embolization and this is after embolization. You can see the control of the bleeding and the closure of the shunt or the fistula or the arteriovenous malformation. Transcatheter embolization, bilateral uterine artery embolization had a primary success rate of 61% and the secondary success rate of 91% after repeated embolization. What does it mean? Primary means control to the bleeding from the first trial to do embolization. Okay, I did bilateral uterine artery embolization and succeeded to control bleeding in 61%. But in some cases, I should repeat the embolization, the uterine artery embolization. And the success rate for the repeated one reach up to 91%. So we say primary success rate is 61%. Secondary success rate is 91%. I hope it is clear enough. Okay? No controlled studies have been performed to evaluate the effectiveness of unilateral versus bilateral treatment approach. This is a matter of research, and I hope many gynecologists can do these researches. What is the difference between unilateral embolization and the bilateral embolization? And what is the effect of embolization according to the material used? Okay? And what is the success rate in primary and in secondary embolization? Okay, transcatheter embolization has provided an alternative and less invasive treatment option for patients wishing to preserve fertility. So we consider it, yes, less invasive than hysterectomy, of course, and also we preserve the uterus and the preserve fertility of the patient. Although up till now we don't know what is the effect of uterine artery embolization as regards the fertility of the woman and the endometrial receptivity, if there is any effect or not. It is not clear up till now. It is a matter of research in the future. Laparoscopy with bipolar coagulation of the uterine artery, another therapeutic option discussed in the literature. Laparoscopy with bipolar coagulation of the uterine arteries. Laparoscopic occlusion of the internal iliac arteries was successfully performed using non-absorbable claps for an acquired uterine arteriovenous malformation. The role of these minimally invasive surgical techniques as a primary or secondary treatment for uterine arteriovenous malformation as well as infertility following such surgeries require further investigation. As I mentioned before, the effect of this minimal invasive surgery like laparoscopic uterine artery ligation, bipolar coagulation, or laparoscopic occlusion of the internal iliac arteries, is it has effect on fertility of the woman or not? This is a question. Could be answered in the future. Okay? Also, I wanna explain something, that this minimal invasive surgery, bipolar uterine artery coagulation or laparoscopic occlusion of internal iliac arteries, can be the first line of treatment, so we call it primary treatment, or secondary treatment, as we may do this minimal invasive surgery after doing uterine artery embolization, so we call it secondary treatment. This is the difference when we say it was a primary treatment or it was a secondary treatment. Okay? I hope it is clear enough. Also, I should mention also that uterine artery embolization, transcatheter uterine artery embolization, could be followed by medical treatment like combined oral contraceptive pills. Okay? Hysterectomy. Hysterectomy may be performed in some cases as a life-saving operation or after failure of other lines of treatment. Currently, hysterectomy is indicated only for those women who don't desire fertility preservation and have limited access to medical facilities. Sometimes we may face a case with spontaneous hemoperineum, a unique clinical presentation of uterine arteriovenous malformation. Imaging which demonstrate the diffuse nature of the vascular malformation would suggest this patient had a congenital arteriovenous malformation. Embolization proved to be an unsuccessful therapy and eventually hysterectomy is required. Okay, it is a life-saving here, and the bleeding is severe. Okay, what else about hysterectomy? Given the acuity of clinical situations that necessitate surgical intervention and the distorted uterine tissue and the anatomy created by arteriovenous malformation, hysterectomy should be performed by those skilled in radical pelvic surgical techniques. This is very important item. So, who will do the operation of hysterectomy? Gynecologist has an experience in radical pelvic surgical technique, because this is not an easy operation, because I may face many problems due to distorted uterine tissue and the anatomy, okay, created by this uterine arteriovenous malformation. So hysterectomy should be performed by those skilled in radical pelvic surgical techniques to avoid any complication. This is the end of my lecture. I hope it was clear enough. I have 3 scientific sites. This one in Amazon containing my books. You can find my books either electronic book or hard copy in Kindle edition, which is the electronic one, or hard copy. Textbook of Obstetrics, textbook Gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy, and the gynecologic oncology. The other scientific site on YouTube channel containing many lectures in OB-GYN, quizzes, case scenario discussion, guidelines, research methodology, and so on. The third scientific site is my site on Blogspot, containing articles and some pictures to my operation. Please go to my scientific sites to find what you need. Thank you everybody. My best wishes for all of you.